So I'm press that button, so we are recording now. It's my pleasure to introduce Jen Raymond to all of you. Some of us have met Jen when she came here generously and kind of introduced her network to our state, and we were hoping to replicate a lot of the work that she has done. And today she'll be speaking specifically on sustainability, which of course is becoming an increasing part of what we are trying to accomplish in Missouri. Jen is the Chief Strategy Officer and Director of the Healthy Living Center of Excellence at Elder Services of Merrimack Valley, a major superstar nationally in this work, and also the Vice Chair of the Evidence-Based Leadership Council. So Jen, thank you again for your time, and I'm going to turn over the floor to you.
Thank you, James. Thank you, everyone, for taking a little bit of time. I know it's early in the morning for you all on a Tuesday, so I appreciate you taking the time. I think one of the things we wanted to accomplish during this call was really to talk a little bit about sustainability and some of the successful and maybe not so successful things that we've seen happen here in Massachusetts and also in other parts of the country. With these networks that are working to integrate the social services, particularly evidence-based programs, with healthcare systems. Since we have a nice manageable size group, we certainly want to have the opportunity for this to be a bit interactive. So please feel free at any time during the webinar, if you're in front of your computer, to type any questions that you have into the chat or the question box, and I'll try to keep an eye on that and answer questions as we go. If you have questions and you want to vocalize them, we'll pause for different times here and there and give people the opportunity to ask questions that way. So again, you know, James is very generous in his description of the work that we're doing here, and I think you'll find something similar with your work in Missouri. This can't be done without a large collaboration of partners. And for us, that includes partners who are, you know, the real core of the work, the boots on the ground that are doing implementation of the chronic disease and other evidence-based programs. Our partners in government who are helping us with structural issues and with policy issues. Also our partners on the funding side, the foundation side, as well as we really see as partners on the healthcare side. So we really want to acknowledge that this is work that doesn't happen in isolation. I know some of you may have heard this before from when I was in Kansas City in the fall, but so I'll go through this briefly just to sort of let you know the Healthy Living Center is sort of the hub, like the hub that you have in Missouri for the delivery of evidence-based programs across the state. When we started this work back in 2013, our vision was really to transform healthcare delivery so that clinical systems, social service systems, and the consumers that we serve. At the time, it was older adults. It's expanded since then, but that those three sectors really collaborate to achieve better health outcomes and better health care, both at a sustainable cost and both at high quality. Our network here seems very similar in some ways and a little bit different in others to you. We have one hub that acts as the center of the statewide provider network. That was something that was really important for us to transition into, to stop thinking of ourselves as a collaborative of community-based organizations, but to use more of the healthcare system language, i.e. a provider network, a statewide provider network of evidence-based programs. We started out by having 7 different regional hubs, and I think that may model a little bit about what you have in terms of having the regional AAAs act as, for lack of a better word, these network leads within specific geographic regions. We have a centralized referral and technical assistance arm, which makes sure that quality and fidelity are adhered to. We take a multi-venue, multi-program, multicultural, across the lifespan approach. What that means for us most primarily, most exclusively, is that not all of our implementation partners, not all of the network providing evidence-based program comes from the aging network, and we'll talk a little bit about that in a moment. We have this one hub at the Healthy Living Center that acts as the centralized entity for contracting. We want to make it easy as possible for anyone who sees value in the work to invest in the work. In other words, for health plans to contract. And we do understand that funding, at least at the current time, has to come from a variety of different sources. So while we have a lot of focus on moving forward with healthcare contracts, we know that philanthropy and other grants still play a significant role in the work, and probably always will if we want to make sure we're serving everyone who needs to be served. And finally, the most key component, I think, in terms of future thinking is the real focus on integrating evidence-based programs in a variety of different healthcare settings. The hub itself in Massachusetts is called the Healthy Living Center of Excellence. We provide training and technical assistance. We have a statewide licensure for all of those programs that do require licensure. It's a bit of a misnomer. I've called it a statewide license here. Really, it is a multi-organization license. So it doesn't cover everyone in the state. It only covers folks in the state who have signed on to the license. It's not an automatic that you get covered under the license just because you're in Massachusetts. And then we'll talk a little bit about that in terms of sustainability. We do some collaborative marketing and outreach, as well as some shared data systems. And we manage the internal quality at the hub as well. Our provider network is about 90 different community-based organizations. I'm going to talk about that a little bit more in a moment, but the provider hub does serve multiple languages, and over the years we have transitioned to being about only older adults to now being about older adults who are adults who are 18 and over. Definitely not older adults, adults who are 18 and over. The reason for that is that many more of our contracting health systems were serving a younger population, and also we found that in many of the communities that we were serving, people were getting sicker earlier, and this real need to focus on management, self-management from an early perspective became more and more compelling to us. So the work has become more about aging as opposed to working only with older adults. And then finally, the last component of the Healthy Living Center I'll mention here is that business development or sustainability component. So we have not stopped writing grants. We are not at a place where we're 100% funded by contracts. However, the number of healthcare contracts and other contracts grow, including contracts with our Department of Public Health, our State Unit on Aging, and consulting with other community-based organizations and networks. We also have developed and administer a couple of evidence-based or evidence-informed programs, and we are really sort of looking at additional innovation. So while we're thinking about how important it is to integrate with healthcare, we're also thinking about the other sectors of the community that touch adults, particularly older adults. So housing, how can we develop contracts with housing? And then the sustainability piece, I'll touch upon briefly the contract with a HUD housing property to deliver evidence-based programs to their members. This is just to give you an idea of the programs and the program breakdown. These are the most recent numbers that we have compiled. They are a little bit stale in that they cover the calendar year 2017. So we're 3 or 4 months behind on getting our 2018 numbers together. As you can see, the chronic disease and the falls programs are by and far our largest programs. When we say the chronic disease program, I'm talking, of course, about the whole suite of programs out of the Self-Management Resource Center, but I'm also talking about some additional programs like Enhanced Wellness, which is a one-on-one evidence-based program. I'll talk a little bit about that. And for falls, that's overwhelmingly our Matter of Balance programs with a little bit of Tai Chi thrown in there, and also our Enhanced Fitness, which is a physical activity program. The place where we're actually seeing the most potential growth and the most sort of forward interest is in our family caregiver programs. They're a little bit more challenging in terms of sustainability. So, you know, even though people are getting more and more interested in them, that healthcare is getting more and more interested in them, they're not quite ready to fund them fully. So our experience has been that the chronic disease and the falls programs are really the most attractive categories of programs to our potential healthcare partners for what I think are probably obvious reasons. And then I wanted to share this quick slide to give you an idea of, you know, what we found to be a really successful model for actual implementation and for sustainability of the work in terms of implementation. I think when we started the work, we thought, you know, senior centers and senior housing are going to be our bailiwick, and the majority of our implementation was going to be done by area agencies on aging. When we look exclusively, and this is the Massachusetts experience, so please take what works for you and leave the rest behind. What we found primarily is that when we focused our work on the traditional aging network partners, i.e. senior centers and housing, we were getting really, really successful at serving a very specific segment of the population. And in Massachusetts, for example, that meant white English-speaking people who live in urban or suburban settings. The rural communities that we serve, the multicultural and non-English speaking communities that we serve, were not really finding a significant home in senior centers and somewhat in housing, but not as much in housing. So if we looked just at the senior centers and housing, we would be serving more than 80% of the people that we serve would be white English-speaking urban or suburban people. When we branched out and started to look at other potential partners, the delivery of evidence-based programs and in the sustainability and growth of evidence-based programs, we found that we were able to turn people who had traditionally been competitors into partners by bringing them into the network. And the most compelling example of that is the alliance of YMCAs across the state. They were able to help us reach a population that's different than what we traditionally reached, also partnering with faith-based organizations and multicultural organizations allowed us to increase our reach and our capacity. The other thing that did for us is that when we were talking with a health plan, for example, and they wanted to refer people into programs, it gave those members, those folks who needed the programs, more choice in terms of where they were going to participate in programs. We didn't have to worry about whether it was an okay fit for a newly diagnosed 45-year-old diabetic to go to a program in the senior center. They felt more comfortable in many cases attending programs at the YMCA or at a faith-based or other setting. So this idea of expanding your provider network and thinking about those non-traditional partners potentially outside of aging or outside of disability might be one of the ways to help with sustainability. It certainly was one of the ways that we were able to increase access and that we were able to assure health plans that we could have coverage for their members in a place that would be comfortable and more conducive to their member actually attending programs. So again, I'm going to keep going, but if you have any questions as we go through, please feel free to type those into the chat box, or I don't know if you're able to unmute yourself, and Kathy, you can certainly let me know if that's a possibility for folks. We can pause and let people ask questions as we go. So the other thing, in addition to looking at the community network itself and the composition of the community network that really helped us improve our sustainability efforts, the other thing that we looked at was the different value that network was bringing to healthcare systems. And for us, healthcare contracts are the #1 source of contract revenue. They're not the #1 source of all revenue, but of all contract revenue. The healthcare contracts are there. In order for us to get our healthcare contracts, however, we did have to have that very expansive provider network that for us included the traditional aging network, public health, housing, faith-based organizations, visiting nurses, community health centers, the YMCA, all of those different buckets of implementation sites are sites that we currently contract with to provide the delivery. When we started the work, and up until about 2 or 3 years ago, we had the state, Massachusetts, divided into at first 6 and then 7 different regional hubs. And the purpose, the thinking behind that was that the regional hubs were going to be able to maintain those local sensitivities. We know things don't happen in rural Western Massachusetts in the same way that they happen downtown Boston or that they happen at the Cape and the Islands. So this model to me looks very similar to the model that you all have with your different area agencies on aging serving as these regional leads or hubs or whatever the language is that you're utilizing. We transitioned away from that a couple of years ago. I wish we were able to maintain those regional hubs. I think that those are really an ideal model, but we're a relatively small state, and we found that sustainability and resources made it a little bit challenging. But what was really important about these regional hubs and continues to be important to this day is the expansion and the variety of community-based organizations beyond the center. So beyond, most of our hubs were led by area agencies on aging. So having the work done beyond the area agency on aging and including folks like our Latino Health Insurance Project or Greater Boston Chinese Golden Age Center to provide the work.
So Jen, can I ask a question? This is Erica.
Absolutely.
Thank you. So you said that you contract with all of these different implementation sites, and that's been critical to expanding your sustainability in all of your regions. And so can you, so when you contract with these different sites, do you also train their staff and embed delivery to offer the program within those contracts?
So yes, we do. Are you talking about train them in the individual programs?
Yeah, so if, at some of the housing sites or the YMCA or any of those different partners you mentioned, community-based organizations, do you train their staff to be leaders as well and to offer the programs with, or where are your leaders embedded?
Yes, thank you. Good question. Absolutely. So we do hold regional trainings, and we train multiple different community-based organizations in each of those regional trainings. So what happens is traditionally, if we're working in a region and say, for example, our area agency on aging is a lead, we'll do some assessment with that area agency on aging to find out what their capacity is, how much they can grow their capacity, which populations they're able to serve, which populations they are challenged with serving, where the gaps are. We'll also talk about the capacity and the gaps with respect to individual programs. If we're trying to move forward chronic disease and falls programs, we want to assess where that lead area agency on aging is. And then work with the AAA to find out who are the partners in the community that can help supplement the work, who can help fill the gaps, whether those are gaps related to particular programs, particular language. And a really good problem is to have is gaps in terms of max capacity. An area agency on aging in Massachusetts here might decide that they have capacity to do 10 chronic disease programs a year, but based on contracts, based on population, there's a need for 20 chronic disease programs. So who are the community partners that can help reach that necessary upward limit? And then we do provide training both in terms of the programmatic piece as well as training on outreach, recruitment, retention strategies, data collection, and a little bit around fiscal management as well. So yes, the implementation sites for us are more than just the central hubs. Does that answer the question, Erica?
Yes, it does. That was really helpful. I think it's helpful for me to hear to think about the implementation sites in non-traditional ways and in a broader capacity as a key component of sustainability and being able to grow and reach other populations and to deliver more programs to meet the need in the community. So I think that's a really, really helpful. That's really important.
Yeah, I will share one of our, I guess we will call them learning experiences. This would have been, 3 or 4 years ago when we started doing the work, and we were fortunate enough to get a small 1-year pilot contract with one of the patient-centered medical homes, a large patient-centered medical home in Massachusetts, in Boston. And when we started getting the referrals were primarily for folks who were under 60 and wanting to get into chronic disease programs. And all of our programs at that time were happening at senior housing or happening at senior centers. So the translation rate from referral to somebody actually getting into the program was somewhere around 3%. Because people were just saying, I'm not going to go to a program that has senior attached to it or has aging attached to it. So that was an unsuccessful contract for us, an unsuccessful pilot. We found that by expanding the partners, we were able to better meet the needs, not only of the health system, because they're not the primary, but of the consumers who actually needed the program. The other sort of cautionary tale that we'll put out there right now, and I don't have a strong feeling one way or the other about philosophically the way people go, but another challenge that we had here is that when we first started talking with our health systems, our health partners around the delivery of evidence-based programs, we focused primarily on selling the programs, delivering the programs that you see on the screen here. And we got really excited when there were health systems that wanted to get involved, and they wanted to get involved by training folks. I do hear a little bit of background, and I'm not sure if it's my echo or not, so I just, in case anyone else hears that, there's a little bit of background.
And I have a question. The assessment that you talked about to identify gaps and capacity, is there a tool that you a standardized tool you use to conduct that assessment?
We didn't use a standardized tool. I mean, I know we have a sort of a one-page, I think it might even be 3/4 of a page checklist of questions to ask, and I certainly can share that if it's helpful. It was really doing some informal environmental scanning around the needs and the capacity. So I wouldn't call it a tool. I think it's just sort of a back of the envelope thing that we utilize. We weren't that sophisticated then.
It's okay. It sounds sophisticated to me. So thank you for sharing that.
So one of the just considerations to have is, when you're thinking about who your partners are there health systems, health plans, healthcare organizations that are sort of knocking on the door, wanting to be part of this delivery system, wanting to be trained in programs, wanting to do implementation for their clients. And I think there are lots of pros and cons to that. I mean, the pro is that the more people there are out there offering the program, the more people that are going to get the program, the more people that are going to be reached. So that's certainly a consideration in favor of including health systems in part of your delivery package. Some of the cons, or one of the cons, really is, if you train people in the healthcare system to deliver the program, they're going to start to wonder what value you, as the community-based organization, bring to the table. If they can do the delivery, what do they need you for? And we certainly do feel like the community-based organizations bring a lot more than just the program to the table. They bring all of the resources and the connectedness and the relationships that you have in the community to the table. You're able to identify if somebody goes to the program, if they need more resources and how they might get those resources. So it is a consideration when you're thinking about your provider network and keeping that model in mind. Do you want to have a model where you have healthcare as part of the delivery system, they're sort of building their own capacity, or do you want them to purchase the work from you because of all of the other value that you bring to the table? So I thought that this would be a good time to pause if there are any questions, and also to maybe do a little bit of thinking out loud as to what you are currently seeing as some of the challenges to sustainability. So I'll go ahead and pause for a moment and see if there are any questions. I don't see any coming through on the webinar, but does anyone have any questions so far?
Jen, one of our major challenges in Missouri has been building this capacity in the exceptionally rural areas. Can you just walk us through your experience in the more rural areas? I'm not really sure. I think you all have some quite rural areas in Massachusetts, but any tips or experience that you could share would be helpful.
Yeah, and I will say, I think a lot of people think of Massachusetts and they equate Massachusetts with Boston and don't think that we have rural areas, and we absolutely do. There are really two different Massachusetts. There's everything within what we call 128, which is the major route or highway that circles around Boston, and then everything outside of 128. And in central and western Massachusetts, we are primarily rural, lots of small towns and long distances between each town. It would be really, really challenging to recruit 10 people to a chronic disease workshop in our rural settings, and we're lucky sometimes to recruit 4 or 5, so certainly that's not enough. We don't have what I would call frontier rural, so I want to be clear on that. But we've talked with a lot of other states around the country who struggle with this rural access piece, and it is absolutely a real challenge. We've seen challenges in terms of leader training and retention. It's really expensive to hold these leader trainings and even these master trainings can be more expensive. So how do you recruit the right people to come to an expensive training, as opposed to what we sometimes get tempted by and do, which is just recruiting bodies. So, you know, it's not unusual in rural settings for us to have leader retention rates under 30%. What I mean by that is less than 30% of people who were trained still doing a program a year later. Some of the other challenges that we've seen are around recruitment and retention, transportation piece, and the cost piece. So some of the things that we've seen be successful, not just here in Massachusetts, but in different parts of the country, have been to have, again, coming back to this diversity of implementation partners, diversity of settings, meeting people where they are. So having sessions at the Grange Hall, having sessions in conjunction with Parks and Recreation, looking at our Meals on Wheels partners as people who are able to identify potential participants, and sometimes being able to even offer interventions, and I'll get to that in a moment. Having programs happen at the church. We've had programs that have happened right after an hour-long Sunday service, and that's where people are congregating, so we're able to catch them there. And housing has always been a traditionally strong place in rural populations to have programs. We also are really keenly aware that some of the programs may need some adaptation to fit well with rural settings. The perfect example of this is the chronic disease self-management program, where the minimum number of participants has been adjusted downward. So it's normally 10 people that you need to start a program. With chronic disease in rural settings now, it's 7 or 8 people to start a program. I think one of the things we don't often take advantage of is talking with the program developers themselves, talking with the people at the Self-Management Resource Center, or at Maine Health, or at Sound Generations, anyone that does the program development, and talk to them about potential approved program adaptations. I'll give you an example right now. There are a couple of different community organizations in rural settings who have approval from the Self-Management Resource Center to offer the chronic disease program in a sort of telemedicine, telephonic way, using something like Zoom or Skype or FaceTime, not FaceTime, I think it's Zoom or Skype, to offer the program so that the workshop is a mix of people who are physically in the room together and people who have access issues and are participating using technology. So we're waiting to see how successful those programs are. I can tell you here in Massachusetts, we did one adaptation with our diabetes self-management program where we had a couple of people participate in the workshop using Zoom, and we had some really promising results. We're still working on ways to finesse that, but the program developers are often very open to talking about adaptations to better reach rural populations, as long as they know you're going to do it with some sense of quality and fidelity, that you're going to be measuring different aspects, and that you're going to be treating this as a pilot, as a test, and share your outcomes and your findings with the program developers to see if there's positive results there and whether you can grow the program. So don't ever be afraid to reach back to Self-Management Center or other program developers to see if whatever innovative or creative idea you have around adaptation is successful. And then the other thing that we wanted folks to really consider is the different program modalities. We most primarily do community group programs. There are one-on-one interventions like enhanced wellness, which is the chronic disease, and healthy ideas, which is a behavioral health, which can work well in rural settings if it's embedded in a case management system, or if you have trained home delivered meals, volunteers, or staff who might be able to offer the program. And then finally, exploring the online or the virtual programs like Better Choices, Better Health. Questions? So I won't go into too many details, but you'll have this up on your screen, and I did send these slides over to Kathy, and she can certainly share them. There are really good examples of rural settings, like folks in rural New Hampshire who have embedded the program in senior housing and in churches, and have found that, the key is to have local trainers. So it's a lot of trainers, but they have very small geographic areas that they cover. Folks in Utah, which has much more of a rural and a frontier setting, they've been embedding the chronic disease and falls programs in their work for almost 10 years now. And their primary successes have been using volunteer lay leaders who live in the community. So it's not staff, it's really people who are the community and represent the community, including retired nurses or retired social service professionals. And that these folks really do commit very specific amounts of time each year to do the implementation. And they're not only people who do implementation, but they're out there rah-rah cheering the programs and doing recruitment as well. So they're outreach, visibility, and implementation partners. James, does that help in terms of rural populations? Are there other things?
No, that is very helpful. Thank you, Jen. Much of the solutions that you kind of pointed out, I think, would help us, although I think there's just a lot of hard work to be done. I believe Erica here at Mark has a question.
Hi, Jen. I think you and I have talked a little bit before about, and I apologize if you're addressing this later in your presentation, but I know kind of some partners, there are barriers to contracting with them to deliver the program if they sit sort of inside a large health system where there's a lot of red tape, and a contract of this size isn't something that the health system would pursue. And I know that you said in those instances that you do have some instances like that, but you try to at least make sure that an MOU is signed. What do you make sure goes into that MOU?
Yeah, that's a really good question, and I thought I had included, and I apologize for not including it. I thought I had included a sample MOU, and I certainly can share that. We have run across partners who really want to do the work, are committed to the work, are excited about the work, but either can't sign a contract, maybe they're part of state government, or they're part of a larger healthcare or other organization that makes it incredibly difficult to get a contract approved. And maybe they have other resources, either real dollars or time commitments or other resources to do the program implementation. In those cases, we don't sign a full contract, but we do have a memorandum of agreement or a memorandum of understanding, whatever your language is. And that memorandum will lay out very simply, I think in about 3 pages, the responsibilities of each party. So the responsibility, for example, of the hub to provide training and technical assistance and assistance with marketing, and up-to-date websites where workshops can be posted on a calendar, fidelity and quality support, all of those kinds of tools, and the responsibilities of the implementing agency instead focus more around structure as to when they're going to offer programs and making sure those programs get added to the statewide calendar roughly 30 days before the workshop happens, so that we can work on strategies to recruit enough people. They agree to abide by all of the conditions of a particular license, for example, with respect to when data has to come in, the maximum number of workshops they can offer. they agreed to submit data within a month after a workshop is completed so that we can really put that data into our one statewide Salesforce database and be able to tell a comprehensive story about what's happening. So it's really more of an exchange of support as opposed to an exchange of resources. And we keep it really small. I think it's 3 pages, and the first page and a half of it is probably just the sort of, this is who I am, this is who you are, this is what we want to do together. And then the last half of it are those very specific but not overwhelming responsibilities of each party. We'd love to get to contract stage with folks because we certainly do want to share the wealth with a lowercase w. Nobody's getting rich on this, but share the wealth in terms of making sure people do the work, are appropriately compensated for doing the work, but we understand that all organizations are going to have capacity to do that. And I'm happy to share the MOU if that's helpful.
That would be very helpful, and thank you for that response. It was extremely helpful. Thank you.
It's very, very straightforward, and we found that it's not overly complicated. So I think the last thing that I wanted to really mention here, I know there's been a lot of focus on sustainability through contracting with healthcare systems, and we really do want to improve this integrated work so that, you know, I'd love to see the day when anybody newly diagnosed with diabetes got an automatic referral into the Kansas City programs or into the Missouri hub. That's sort of the dream, and that referral was something that was paid for. What we found to be the most successful way of marketing these programs in terms of sustainability, not just to healthcare, but to any potential payor, is to not market them as a program. Here's a chronic disease program. We want to offer you 6 weeks, 2.5 hours at a time, all about the symptom cycle and the toolbox and improved outcomes, but instead starting with a very simple question of asking any potential payor, you know, what is the primary problem that they have? What is keeping them up at night when it comes to their clients or their members or their consumers, and then framing the work around how you're going to help solve that problem. So if it's in a healthcare setting, in a physician practice where the primary problem might be no-shows, how does the chronic disease program positively impact no-shows? Well, you're working on people becoming more activated, you're improving communication with their healthcare system. All of those things we think are going to lead to people showing up more. If you're talking with a housing authority, for example, or a HUD housing site, and they're saying one of their primary challenges is that they really want to keep people in tenancy as long as they can. The turnover of tenancy costs money. We lose money in tenancy turnover, so how do we keep people in their rental unit as long as possible? Well, you know, keeping them healthy, having them being more activated, making behavior changes that are to keep them independent, that's how we're solving that problem. So I think that just one simple tweak in how we talk about the work, from it just being about a program or a service to being about solving a problem, has been a really strong transition that we've made that has led to greater sustainability. So that's kind of what I had for today, and I'm happy to sort of pause and open it up for questions. I know we get about 15 or so minutes left. Maybe I'm looking at the time wrong. Anyone have questions or comments?
Jen, this is Kathy. Thinking back on your very early days on this, what were your challenges back then? You know, you've had such long-standing success now, so it's really thinking back on where we are here in Missouri what were your challenges in that first year or two?
Yeah. I'm going to take two different cracks at this, and I'm going to say our overwhelming challenge, 10 years ago or 8 years ago when we really got embedded in doing the work is very similar to one of the overwhelming challenges today, and that is recruitment. I don't think anybody sort of cracked the egg on how to easily recruit people into evidence-based programs. These are not sort of like your sit and pop in whenever you feel like it, knitting class or chair aerobics, all of which have value, but we're really asking people for a strong commitment, and 2.5 hours a week for a month and a half is nothing to sneeze at. That was the primary challenge back in the day, and it continues to be a primary challenge today with a little bit of a tweak. Now we're focused not just on getting people in the seats, but getting the quote unquote right people in the seats. How do we catch people who are not already somewhat activated, right? If we put up the flyer, put it in the newsletter, or talk it up, people who are, really excited and a little bit motivated are most likely the low-hanging fruit that we get. But instead, how do we encourage people who are less activated and maybe less inclined to make behavior change to give the workshops a try? I wish I could say that was a challenge that gets easier over time. It's one that I think continues to be up near the top. Some of the ways that we've been able to morph and move forward and improve on the recruitment piece has been through the diversity of partnerships, not just with community-based organizations, but with healthcare systems. We know that not everybody is going to see as great as we think we are. We know that everybody is not always going to see the Area Agency on Aging as the place that they find a home, but they will find a home in the church. They will find a home in housing. They will find a home at their multicultural coordination center or at the YMCA. So how do we diversify those partnerships? And then how do we diversify the partnerships with healthcare through contracts? Because there's still a large number of folks who, when their doctor or their health plan says, here's a referral for you, will take up that referral, or will at least look at that referral more seriously than if it comes from somebody outside the healthcare system. So that's one thing that I would say was a primary challenge back then. The other thing that I would say when we started was another primary challenge for us, and the place that we've had both is really around the culture changes. Many of our community-based organizations were very used to funding and resources coming from sites. I think there's a little bit of background noise, so maybe it's just me. So I just want to make sure everybody who's
your lines.
talking doesn't realizes that other people may be hearing their conversation. So one of the challenges back then was culture change piece, that we were very used to funding coming from either our Title III dollars or coming from grants, and the level of accountability to a funder, to the state unit on Title III, is very, very different than the level of accountability to an accountable care organization or to a patient-centered medical home or other physician practice. So making that transition, with our state unit, the number of people that we reach was the primary indicator of success. With most of our healthcare partners, cost savings and improved quality are primary indicators of success. So how do we make that transition?
So Jen, we have had quite a few conversations with some local healthcare providers, and This issue of appropriate, sustainable referral processes in a healthcare setting is tremendously challenging. I don't see a very clear path forward. Do you have any success stories with actual clinics that are referring or anything like that?
Yeah, I think that the most success that we've had in clinic kind of settings for us, surprisingly, has been with some of the PACE sites, the Programs for All-Inclusive Care of the Elderly, where they're already very forward-thinking in terms of the impact of social determinants, the impact of factors outside of the clinical system on health. So because we have those similar motivations and those similar ideas, we've been able to work with PACE sites a little bit more successfully in terms of reaching their populations. I think the other benefit is that people are very used to going to the PACE site for a whole variety of services, so it provides a convenient location that they're already comfortable with. But I think the clinic systems are really, really challenging, particularly because of the limited resources that they really have to do this work. They're working on a shoestring. They have not, when I say, successful partnerships, we have not had any success in contracting with those clinic-based systems. We've just had success in identifying people who are appropriate and offering the programs. Sometimes we're able to tie them back to their health plan and be able to get reimbursement that way, but not in terms of a direct clinic reimbursement. The only kinds of healthcare systems that we've had contracts with that have helped the evidence-based programs move forward have been managed care plans, including our dual eligible plans, and accountable care organizations.
So Jen, of your total participants reached every year, what proportion of those are reimbursed right now?
Great question, great question. So last year, 2017 was our biggest year. I think 2018 is going to be right on par with that. But even with that being our best year, it really is about 33 to 35% of the people who are coming to programs are coming and being fully reimbursable. And what I mean by fully reimbursable is that they're coming and we're getting paid by a health plan or an accountable care organization for that person participating in the program. We do have a couple of contracts where we get paid for outreach and marketing. So people who don't fully participate, we might get a partial payment for. But I'm just thinking right now of people that we get fully reimbursed for, and I think it's about 35%. So that means that when we are looking at the rate, we're having to make sure that the rate covers the cost not only of that person who's participating, but a margin that allows for additional people who haven't come as the result of a reimbursement to participate. And our margin is important in that way.
So thank you. That's very helpful, Jen. So the remainder of those completers, are you funding that through philanthropy, Older Americans Act? I mean, how do you sustain that? I presume that the program providers receive an equal compensation for those who are reimbursed to the network hub versus those who are not?
Yeah, absolutely, absolutely. So we have federal grants, we have some local philanthropy grants. The most successful philanthropy we've had are those foundations that are attached to a health system. They get it and get really invested in Older Americans Act. Those are the three biggest ones, in addition to the revenue generated from contracts that are fully reimbursed. I do have, and I was looking, and I don't think I have it included here, but I do have a couple of charts that show the revenue 2013 compared to 2018. I didn't include it here. I should have, but I can send it over.
Thank you. I would just like to invite other partners across the state. If you have any questions or anything you'd like for Jen to comment on, please feel free to speak up or type in the chat box.
So I do appreciate the time, everyone, today, and Kathy and Erica and James, I'm certainly more than open if through further conversations or people do some thinking, they think of questions and you want to send me an email with a list of questions or set up another short call to do that. I'm always open to continuing the conversation. We have a vested interest, even way over here on the East Coast, in more and more of these networks being successful. We've had other networks who have even been approached by employer groups to say, we have an insurance plan that covers employees in Texas and Florida and California. How do you offer these programs to all of our employees? We can't do that. So the more of these networks that become operational and successful, the more we all benefit. So I appreciate you taking the time today, and I'm happy to answer any other questions that you have through the email or through another call.
So while others are thinking of questions, something here at Mark that's just happened in the last couple of weeks is really, I think, solidified in my mind, and this may kind of go under your heading of culture change. But with our work with MSN, which is a little different than the CDSME grant, one of the conversations that James has had with a potential payer, and I've forgotten, James will have to help me, but it's a very high-level protocol that they are expecting of Mark around our security system with email. So whatever that term is.
Yeah, we've entered into a negotiation with Blue KC, that's a Blue Cross Blue Shield outfit, ostensibly, and they have required a cybersecurity risk assessment of the agency here at Mark, and by extension, all of our providers in the community. And the standards, these healthcare standards, are just absolutely rigorous with regard to cybersecurity standards.
So, but for me, that this raised a question of just how much change, because this isn't the way we've typically done business, to have that level. This is even Mid-America Regional Council, not just the Area Agency on Aging, to have that level of sophistication that our potential business partners are going to require. And so, the ripple effect is that the culture change, that we have to see this as a business, but still do the work of our mission. So do you want to comment on that, or have some examples of organizations that you've seen that have successfully made that switch? And finally, just, I guess, advice for everyone on the phone with what's in store for us.
Yeah, I think you've asked a question that I wish I had a clear-cut answer to. When it comes to the culture change piece, it's an ongoing effort, and I think it's not something that happens overnight or even happens in a year. What we found is two things to be most important in talking with our community partners. Sorry, I keep hearing the echo, so I'm pausing here and there. In talking with our community partners, two things sort of stick out in terms of the most important pieces of helping culture shift, helping culture move around. The first piece is the communication across the hub, and making sure that folks are not really up to date is the wrong way to frame it, but when you're talking about a new initiative, a new contract, a shift, that you're talking with your community partners well before the time that anything gets signed, that you're talking to folks when an opportunity becomes a possibility as opposed to when the opportunity becomes a reality. And having people engaged from that beginning point is much more important and much easier than sort of bringing on, hey, we got this new contract and these are all of the things that you have to do. So the earlier you can communicate across the network from the hub and all of the community-based organizations, the better it's going to be in terms of helping culture shift. And the other piece that comes across really loudly is that we need to focus on the why we're doing the work much earlier and much more intently than we currently do. Much of our focus now is on the what are we doing, and instead of sort of thinking about the why, and that why really begins with creating. I'm going to quote John Cotter and his book, creating that sense of urgency so that everybody understands. This is not just us coming out and saying something that you should do. This is something that we must do if we're going to ensure our future in this space. As with any kind of culture change, there are folks who are able to move forward with it quite easily. There are folks that need additional support moving forward, and then there are folks and organizations that are just not going to get there. So it doesn't surprise me when there are organizations or networks that look one way on day 5 and are composed in a very different way on day 305. So I apologize for not having a really concrete answer. I would say that people who don't rush culture change are more successful than people who just try to turn the switch. And creating that sense of urgency is really the most important, critical first step.
Thank you.
Yeah, it's a hard piece, but it's absolutely necessary. I had a health system leader talk to me recently. We were working on a contract, and he was really excited about the contract in certain parts of the state and less enthused about it in other parts of the state. And he said, Jen, the problem with community-based organizations, and he said it that way, the problem with community-based organizations is that they're not data-driven. You don't make decisions based on data. You make decisions based on what you think is right for participants, or what is right for consumers. And I was like, both things can be true, so that's culture change. That's accountability. I don't think community-based organizations want to and necessarily should be these purely data-driven machines, but how do you transition from being focused squarely on the mission to being focused squarely on the mission, but having your decisions be influenced by data, being influenced by outcomes, being influenced by those things that healthcare puts as a premium. So we're still trying to find that sweet spot in between.
So I've been looking at my phone to see when our next sustainability work group, and I'm not finding it, but I know that we do have one scheduled. If folks feel like this is a topic that you want us to put on the agenda, the discussion that we've just been having over the last 5 minutes, let us know. I think it just seems like this is really an important, critical discussion for us to be having. But I can't find when that meeting is on my phone.
We're still scheduling it. People gave you their availability, I think.
But I think I actually
did.
Yeah.
Absolutely.
All right, well, unless there are any further questions, Jen, we'll pause after I say this, but I do just want to express our gratitude again for your time and expertise. It really has been critical as we've kind of envisioned setting up a network in Missouri. So thank you not only for your work in your state, but influence across the country.
Well, thank you, James, and I will share for all of you, there are lots of eyes on what's happening in Missouri and the work that you've done so far to come together as a network and to think about how you best serve your clients and your consumers by creating this integrated work is something that is really exciting to see, and you're certainly on the forefront of moving things forward. So anything we can do to help, please let us know, and I wish you all good luck. It's very exciting.
Thank you.
Thank you.
Everyone.
Bye.
Okay.